Hello and welcome to our second talk in our monthly clinical genomics webinar. I'm Mariam, the Science Communication and Marketing Officer at GenomeArc, and today I will be hosting our guest, Dr. Marc Woodbury-Smith. Dr. Woodbury-Smith is a clinical senior lecturer involved in research about autism spectrum disorder. He's also an honorary consultant psychiatrist in the Complex Neurodevelopmental Disorder Service, and he provides tertiary level assessment for children who have or are suspected to have autism spectrum disorder. It's a very interesting perspective from both a scientist and a clinician, and we're very excited to learn more about it today. So, hello, Dr. Woodbury-Smith.
Hello, let me just share my presentation.
By the way, is there anything you want me to add or edit in the intro? I can do that.
No, that's great. Yeah, thanks.
Okay.
Can I just check that you can see these slides?
Yeah.
Okay, that's great. So thank you for the introduction. I'm going to talk about clinical genetic testing as a psychiatrist who works in a neurodevelopmental clinic. And just to provide a little bit more about myself and my background, essentially, I've been an academic psychiatrist working with children with intellectual disabilities and autism spectrum disorder now for over 20 years. I have an academic research background in the genetics of neurodevelopmental disorders, and I have a particular interest in the translational potential of genetics research, and hence my interest in clinical genetic testing. I have a couple of disclosures there on this slide that are of no relevance to any of the content that I will be presenting. So the clinic I work in is a community geographically defined specialist clinic for school-age children, so children aged between 5 and 18 years, who have an intellectual disability, but who also present with significant other challenges. These are often behavioral challenges, but also there is typically an underlying comorbid secondary diagnosis such as depression, anxiety, and so forth. Now, the majority of the children that I see also have autism spectrum disorder, and many also have a diagnosis of ADHD. And I would also say that around about 20% also have epilepsy. So as a service, we offer pathways for diagnosis for ASD and ADHD and for medical management of behavioral challenges, other comorbid disorders, and also non-medical management for a number of different areas of need, including adaptive skill vulnerabilities and social and communication vulnerabilities. Now, most of the children that I see in the clinic at the time of speaking do not have a genetic diagnosis. And many, and this is what is particularly striking, many have not been offered a diagnostic test. And it was really in view of this that in the last couple of years, I have planned to set up a clinic for genetic diagnosis in this population, with some of the barriers to actually undertaking that, meaning that it's still an ongoing process. So currently, I have about 120 patients on my caseload. And here is a breakdown of their genetic diagnoses. And there's nothing terribly surprising here. Down syndrome will be the commonest diagnosis in a clinic such as the one I work in. But you'll also see a number of other diagnoses, such as 16p, 11.2, 15q, 13.3, and so on. It's unusual that there's nobody with a diagnosis of Fragile X. Typically, we would have 2 or 3 children who also have that diagnosis. But I think what this illustrates is that it's only a very small proportion of the patients that I see that have a genetic diagnosis. And the majority, as I mentioned before, haven't even been offered a genetic diagnostic test or been seen in a medical or clinical genetic service. So what I'm hoping to present an overview of in this presentation is to talk about what we know about the yield of diagnostic testing, to talk about obstacles to diagnostic testing and other considerations that need to be taken into mind when setting up a genetic diagnostic clinic. And clinical geneticists, and obviously I'm not a clinical geneticist, will be aware of some of these considerations and obstacles in their everyday practice. Now, before I launch into those aspects of the presentation, I'm just going to talk a little bit about classification, epidemiology, and etiology in relation to neurodevelopmental disorders, and more specifically, intellectual disability. So to bring us up to date, we are currently using either the DSM-5, the Diagnostic Statistical Manual of the American Psychiatric Association, version 5 came out in 2013, or the World Health Organization's International Classification of Diseases. We're on the 11th iteration, which has had a long gestation period. And I'm not sure if it's officially out yet, but certainly over the last year or two, we've been hearing more and more about what the ICD-11 looks like and how it relates to the DSM. So both of these categories are identically termed neurodevelopmental disorders in both DSM and ICD. And what you'll see is that ICD and DSM have essentially converged on both the terminology used and the actual disorders that make up this category of neurodevelopmental disorders, with some minor differences. But if you drill down into all of these different areas, what you would see is, generally speaking, the diagnostic criteria are almost identical between these two. At this point, I should point out that the diagnostic criteria for intellectual disability essentially comprises three main areas. One is the onset is before the age of 18 years, or at least the onset is during the developmental years. Secondly, there's an impairment in global cognitive function, and that's usually evidenced by an IQ assessment of below 70. And there also has to be an impairment in adaptive skills, so in everyday social communication and behavioral skills. And again, you can measure adaptive behavior using a similar scale to that used in the IQ assessments. And so you'd expect an adaptive function to be 69 or below. Now, ICD and DSM, you notice here, use different terminologies for intellectual disorders. So the DSM, we're talking about intellectual developmental disorder, and ICD, disorders of intellectual development, but their diagnostic criteria are identical. Now, one thing that is striking about all of these neurodevelopmental disorders is that there's a high degree of comorbidity. So particularly for intellectual disabilities, and this is evidenced in the clinic I work in, and probably in other people's experiences of clinics that they might work in, intellectual disability is characterized by high rates of comorbidity for all of those other neurodevelopmental disorders that were on that previous slide. And just by way of illustration, here's data on the overlap between ID, intellectual disability, and autism spectrum disorder. On the left-hand side is a figure demonstrating the prevalence of intellectual disability in autism samples. And on the right-hand side is a graphic demonstrating the prevalence of autism in intellectual disability samples. The overlap is around about 50% among individuals with autism also have a comorbid diagnosis of intellectual disability. That's changed quite a bit over the years, actually, as the idea of autism has become more of a spectrum, and as individuals who function intellectually in the normal range represent now a big part of that. The comorbidity for intellectual disabilities has come down from above 70% to below 50%. But if you look at samples of individuals with intellectual disability, particularly those who have moderate to profound intellectual disability, you'll see that many of them also have a diagnosis of autism spectrum disorder. And this is probably unsurprising. If we look at the genetics of these different neurodevelopmental disorders, we see a lot of overlap in the identified genes. This is a paper that was published a few years ago now, but what it essentially attempted to do was look at those genes that are known to be associated with ASD ID, EE is epilepsy, and SCZ is schizophrenia, and look at whether this overlap is more than you'd expect by chance. So if you cast your eyes to that crazy looking Venn diagram there on the right hand side, you'll see that the overlap between two disorders, such as ASD and ID, or ID and schizophrenia, is quite common. And actually there are, I believe, 49 genes there where the gene overlaps between any two of those disorders. And then on the left-hand side, the authors of this paper attempted to determine whether you'd expect such an overlap by chance by undertaking permutation. And what they found is that with data such as these, you'd expect perhaps 20 genes to overlap by chance, but certainly not 49 genes. So this is not just a coincidence. And if you look at the genetic architecture of any of these neurodevelopmental disorders, it's actually pretty identical. Now, this is a graphic taken from a paper published in 2015, which delineated the genetic architecture of autism. But I argue that you could equally apply this model to intellectual disability, to ADHD, and beyond, to other common complex disorders, such as rheumatoid arthritis, inflammatory bowel disease, and so forth. I will just basically just describe what is going on in this cartoon graphic. On the far left-hand side, these are four trios. On the far left-hand side, you'll see an example of a highly penetrant mutation that's de novo in the offspring, resulting in the phenotype, whether it be ASD or ID. So these are single gene disorders. On the far right-hand side, this is an example of polygenic risk. These are variants that are individually quite common in the population, but individually do not confer much susceptibility unless you have enough of them to take you over the threshold for expressing phenotype. And then in the middle, you have a combination of polygenic risk and variants of lower penetrance. And as a model, this is very useful, as I mentioned, but it's very useful in terms of how we understand this overlap between these different neurodevelopmental disorders and why we see, for example, in the clinic such as the one I work in, so many children that have all of these diagnoses. This is just a slide to remind me to mention that we do know, of course, that there are environmental factors that also can cause intellectual disability. The focus here is obviously on genetic factors, but prenatal infections, malnutrition during early childhood, and toxins ingested during pregnancy or during the neonatal period can all result in the subsequent development of vulnerabilities in the cognitive domains. And for some, this will manifest as global developmental disability, a term, by the way, that's typically used up until the age of about 6, and then intellectual disability, which is generally used to describe something that is at that point permanent. Among those with developmental disability, they won't necessarily go on to get a diagnosis of intellectual disability, although many will. In terms of intellectual disability genetics in the clinical setting, this has a long history. Here are some examples of karyotypes. So, you know, as early as the 1950s and 1960s, we would have been diagnosing Down syndrome there on the left, Fragile X syndrome there on the right, and Klinefelter syndrome, XXY, there in the middle. To be fair, Klinefelter syndrome is not an intellectual disability syndrome, as most individuals that have a diagnosis of Klinefelter's actually function intellectually in the typical range. But people with Klinefelter's often struggle at school. They have academic difficulties, they have specific learning difficulties, and also can have behavioral challenges that result in them attending the clinic that I work in. And we should also remind ourselves about the number of genes on the X chromosome that are associated with intellectual disability. This is a fairly recent study from 2018, which basically curated known penetrant genes that are on the X chromosome that are known to be associated with intellectual disability. And what you'll see here, if you look at the graph on the right-hand side, is that there are around about 140 known X-linked genetic syndromes associated with intellectual disability. And some of the genes there on the left-hand side will be familiar to us, such as the neuroligin genes, MECP2, the cause of Rett syndrome, and RAB39B, another cause of autism spectrum disorder, intellectual disability, and early onset Parkinson's. In relation to diagnostic yield, which I'm going to be giving you some data on shortly, the ability to have good diagnostic yield is obviously based upon single gene discovery. And what you'll see on this graphic is that single gene discovery has increased quite substantially over the last 10 years or so. So this is a graph showing single gene discovery from 1980 onwards, and the number of genes is described on the y-axis there. And you'll also see on this graph human genome sequencing introduced around about the early 2000s. So two things to say, really. One is that gene discovery was happening before the introduction of human genome sequencing, because the steepness of that slope doesn't really change much at that point of human genome sequencing introduction. But the second point is what you'll see is the slope indeed does change around about 2010, and we see a rapid increase there in the number of genes identified associated with intellectual disability. And that essentially coincides with the introduction of massively parallel sequencing, but importantly, a cost reduction and the more wider availability and affordability of whole genome sequencing, both in the research setting, but also in the clinical setting. So in relation to diagnostic yield, as you would expect, it mirrors that graph that you saw in the previous slide on the right-hand side. So the graph here on the left-hand side shows the diagnostic yield for intellectual disability, again over time from 1970 onwards. And it's really with the advent of whole genome sequencing that you see this slope increasing in relation to diagnostic yield for intellectual disabilities. Now, the figure there on the right-hand side is perhaps too small to see in detail, but what it shows is that if you compare yield from conventional cytogenetics with exome sequencing and genome sequencing, you see quite significant differences. So on the left-hand side in green is cytogenetics with generally a yield of about 3 to 5%. And on the right-hand side, you'll see exome sequencing and genome sequencing with a yield of around about 20 to 30%, with some outliers there. Those outliers are presumably due to the bias in the samples that were recruited. So, for example, in a specialist clinic that sees children with congenital abnormalities, perhaps craniofacial dysmorphology and so forth, you'd expect the yield to be much higher. This is a useful paper because it summarizes by systematic review what the yield is in intellectual disability and beyond. Now, this was published in Epilepsy, the journal, in 2021. So this is really a study about epilepsy, and that's why, if you look at this table, the number of individuals with epilepsy is far higher than those with intellectual disability or autism spectrum disorder. But it's useful in as much as it collates together a number of cohorts and gives us information on a sample of nearly 3,000 individuals with intellectual disability who underwent clinical sequencing. So if you look at the ID row, intellectual disability row there, you'll see the diagnostic yield is around about 30%, slightly less than 30%. But if you take the 95 confidence interval, you'll see that we would expect about 1 in 4 to 1 in 3 children who have an intellectual disability to get a genetic diagnosis from clinical sequencing. The yield for epilepsy is very similar, by the way, if you look at the middle row there. And actually, the yield for epilepsy with generalized seizures, particularly if those seizures were of neonatal or infantile onset, is far higher, closer to 40%. What's also interesting is that the yield for autism is also quite high, around about 17% according to this collation of just over 1,500 cases, and that's largely consistent with other studies looking at yield in autism spectrum disorder. Now just cast your eyes down now to the figure 4 from this same paper. This examines yield in exome sequencing versus panels. These were, I'm assuming, epilepsy panels, but I would need to go back to the data to clarify that. But essentially, the yield is not much different from panels versus whole exome sequencing. So the yield for exome sequencing, you'll see, is 27%, and the yield for disorder-specific panels is around about 22%. Just as an aside, excuse me, just as an aside, the diagnostic yield for autism was examined in this community sample of children that were diagnosed with autism in a community clinic and then sent for clinical genetics testing. I appreciate there's a lot of information on this slide, but I'll draw your attention to what I believe are the most important aspects. So this is a study of 258 children who underwent chromosomal microarray, and the yield was around about 9%. Now this was carried out in 2015, which might explain why now the yield is significantly higher than that. But I also draw your attention to the fact that the categories based on minor physical anomalies and birth defects earmarks difference in diagnostic yield. So according to phenotype, these 258 children were divided into essential, equivocal, and complex. Now, the complex children were those that presented with not only autism, but other developmental vulnerabilities. So this may be autism plus another diagnosis. It may be autism plus growth abnormalities, plus craniofacial dysmorphology. And this categorization was undertaken by a clinical geneticist. So for those who fall into the complex category, again, still with the chromosomal microarray, there were 53 of those that fell into the complex category. The yield was 24.5%. So the point is that if you phenotypically characterize your children with autism, you can increase the yield quite significantly. And the same is true of whole exome sequencing in the 4th row there, which goes from about 8.4% up to about 16-17% for those that have a complex phenotype. I suppose the other takeaway message from this is that at the time, chromosomal microarray was as good as, if not better, than whole exome sequencing, although from the last slide I just showed you, that's probably not true anymore. Now, generally in clinical practice, or certainly in the UK, we're not undertaking whole genome sequencing on children diagnosed with intellectual disability. Instead, we're using one of the gene panels. And this is a study from 3 or 4 years ago looking at the diagnostic yield of different gene panels. So these are all children that had undergone karyotyping and cytogenetics to rule out Down syndrome, Fragile X, and those commoner causes of intellectual disability. It's a relatively small sample size. You'll see there the total is 48 patients. But of those 48, the diagnostic yield in the second from last column at the bottom is 10. So 21% of those 48 patients were given a genetic diagnosis by using these panels. Now, clearly, this is a small sample size, but nonetheless, this is largely consistent with the other data that I have shown you so far. We would expect a diagnostic yield of around 1 in 4 children who are genotyped. Now, there are 4 different panels used in this study, or panels studied in this study. And what you'll see is the yield varies by panel used. Essentially, it looks to some extent as if there's a correlation between the number of genes in the panel. For example, gene DX has more than 2,000 genes, and the diagnostic yield, the number of patients with identified causal variants. That's not strictly true because the MNG panel also has a relatively high diagnostic yield, whilst only capturing 361 genes. So clearly it's the nature of the genes on the panel that are important. And clearly there will be some genes that have much more evidence of causality than others. And we would hope that those genes are, at least those genes, are on any panel. Now, I anticipate there's around about 1,000 of those genes that we can convincingly say are causal in relation to intellectual disability. So we probably would expect most gene panels to have around about 1,000 genes on them. But on saying that, if you look at the data, there are many, many more genes that are possibly associated with intellectual disability. We're just waiting for the accumulation of evidence. Now, what is also striking about this study, not illustrated in this slide, is that among those 48 patients tested, 85% of them also had variants of uncertain significance, VUSs, sorry. For any one individual, the median number of VUSs was around about 3 or 4. And these variants of uncertain significance have been described as the most maligned result in genetic testing, because for clinical geneticists, it's difficult how you translate that into information that you can then share with families. Now, to be fair, the American College of Medical Genetics has divided these uncertain significance variants into different categories, as illustrated on this graphic here. And these categories will vary according to their posterior probability from between 90%, which seems fairly likely to be pathogenic, right down to 10%, which seems very unlikely to be pathogenic. So we've seen some best practice guidelines emerge as a result of the uncertainty about which of these variants should we be reporting back to families. So here's an example of a best practice guideline that came out in 2020. This is the Association of Clinical Genomic Science in the UK. Their suggestion is that any of those that fall into the VUS category of hot or warm should probably be fed back to families, with obviously the caveat that these are still of uncertain significance, whereas those below that should probably not be fed back to families, at least not until there's the accumulation of more evidence that would tip them in one direction or another, i.e. tip them towards pathogenicity or away from pathogenicity. In relation to that last point, clearly we will accumulate evidence in relation to genetic variants, and this accumulation of evidence will be partly bioinformatic in nature as we learn more and more about functional consequences of, for example, missense mutations in genes where we know that a loss of function mutation would cause the phenotype. And so the question is, if we identify particular variants as more likely to be pathogenic, do we have a duty to go back to those families on the basis of that information and report that new information? There's actually an emerging discussion around this in a number of different journals. And here is one example that I would encourage you to have a look at. This is from the Journal of Medical Ethics, published this year. asking that very question: is there a duty to routinely reinterpret genomic variant classification? Now, they point out that if that was the case, it would take about 70 years to get through patients in Australia, for example, as an example. And here is a couple of quotes. So from the European Society of Human Genetics, it states, and this is quoted from the paper, if it is decided to change a variant from one class to another, that there is a responsibility for the lab to reanalyze available data, to reissue a report, and to recontact referring clinicians. And then presumably it's up to the referring clinicians what they then do with that information. But perhaps more importantly is this quote: "We suppose that a point in time can be found where the relative benefits of reinterpretation will justify diverting the allocation of resources from alternative healthcare activities." Certainly working in a country where there is limited resources, and if you are borrowing or if you are increasing service provision in one area, that has to come from another area that then has its service provision reduced. We expect at some point in the future that there will be a cost-benefit analysis that argues that for some of these variants, there is a justification for reinterpretation and going back to families. This is a very difficult ethical question. And like I say, I encourage you to at least have a look at this paper, but there are many others that have attempted to address this question too. Another question about clinical testing is, what impact does it have on the care of the child that gets a genetic diagnosis? So on the one hand, we provide families with information about the cause of their intellectual disability or other neurodevelopmental diagnosis. But does that then have an impact on care received? And in this paper, that very issue is looked at by looking at a number of different studies and looking at whether the genetic diagnosis impact on the care received in the short term, and that's what this forest plot shows, and in the long term. So the number of patients for whom there was actionable genetic variants, i.e. the identification of the variants or the syndrome or the diagnosis changed their care, was around about 8% of patients. That was in the short term. In the long term, the figure is around about 10%. So again, we need to make a judgment as to whether that's a substantial figure enough to warrant increasing the degree to which we test families. And here's another example of a very similar analysis where not only have they looked at the yield of genetic testing, but they've looked at whether that impacts the care that the children received. So this is a sample of 500 of whom, if you cast your eyes down that flow diagram on the left-hand side, 36 had pathogenic findings. Now, 9 of those were positive for Fragile X. The others were positive for a range of genetic abnormalities. But the important point to come out of this study is that medical recommendations were made in 26 cases. So of those 36, most of them had medical recommendations as a result of the genetic diagnosis. And in my mind, that's quite substantial. So what are the challenges then of clinical genetics testing? So this is genetics translated into a clinical setting. Well, the availability, so although in some jurisdictions, genetic testing might be freely available and readily available, in others that may not be the case. There's that point I made earlier about arguing the case in the setting of limited resources. There's the issue of the interpretation of results, and with new machine intelligence algorithms, we would expect over the next few years to see better categorization of some of these variants. There's the issue of the patient understanding of the purpose and the risks and benefits of genetic testing. If families are approached, even if their child is still very young, they often say, what is the point of doing genetic testing? How is it going to change the care that my child gets? There's the issue of capacity to consent to genetic testing. The point about arguing why it's important is sometimes quite difficult to make. And we are often asking decision makers fairly difficult questions on which they can then base a decision onto whether to go ahead or not. There's the issue of patient compliance with genetic testing. I see young children with significant behavioral challenges who are often non-verbal and who really would not comply with phlebotomy. And then there's the wider public acceptance of genetic testing. And this brings up a debate that we don't have time to go in, but for example, autism spectrum disorder, whether you see it as a disorder or a difference, does impact whether you believe that genetics testing is the right thing to do. Some would argue that we shouldn't be testing it, that we shouldn't be testing individuals that have a diagnosis of autism spectrum disorder because it's not a disorder, it's merely a difference. Now, one thing I haven't talked about is perhaps the most important, is what about people with intellectual disability? What do they think about genetic testing? And here's an example of a paper published fairly recently, which is a systematic review of people with intellectual disability regarding what they think about genetic testing. It's a qualitative study, and here distilled down are a few of the thoughts that the people expressed. So, for example, some of them said, well, it's a freedom of choice for prospective parents to have genetic testing. Others said it will help prepare the family and to anticipate problems that might occur. Others said for them, it helps them develop more insight into the nature of their disability and vulnerabilities and guides how they should look after themselves and what their future might look like. Others pointed out it's good to know this early on and to avoid unnecessary investigations. And I can think of one example where someone points out that, you know, they've been through a lot of testing over the years, and actually that could have been averted if they had genetic testing early on and the questions were answered early on. Now, what I take away from this paper is that among people with intellectual disability, they are largely positive towards the idea of genetic testing. So what are the benefits of early genetic testing? So access to treatment, having information about prognosis, being able to monitor risk. So for example, earlier I highlighted RAB39B as a gene on the X chromosome that's associated with autism spectrum disorder, but we also know that it's associated with a high risk of early onset Parkinson's during the 20s, when the person's in their mid to late 20s and early 30s. So having that information would be quite useful from a monitoring point of view. The other benefit is that families are able to access support and advice. So organisations such as Contact in the UK provides families with support and information and allows families to link together so that they can ask questions of each other. And certainly patients under my care often reach out to other families, and it's very easy to do that now. And as I pointed out before, it's about that level of understanding, that level of insight that people find quite useful and quite important. Now, beyond the clinical, the translational aspect of genetic testing, of course, what we hope is that this can also lead to greater insight into the pathophysiology and the pathogenesis, I should say, of these diagnoses, whether it be intellectual disability or autism spectrum disorder, because it's only through the accumulation of evidence that we will be able to get greater insight into what the pathways in the brain, which pathways in the brain are impacted, for example. And here's an example of how genetics can inform drug repurposing. So this is from a study, an in silico study published in Frontiers in Pharmacology, where they essentially looked at gene networks for autism and aligned this with known compounds that impact on those gene networks, whether or not these compounds are known to be useful in autism or intellectual disability. And in this way, you can begin to develop maps of potential targets for compounds that could be repurposed in a clinical trial. So in conclusion, intellectual disability is multidimensional and most commonly caused by genetic factors. There are many thousands of causal genes and loci that have been identified and are amenable to identification using a wide variety of technologies, but more recently, whole genome sequencing. Identifying the etiology of intellectual disability has significance beyond the intellectual disability itself, as articulated by people who have a diagnosis of intellectual disability. But there are a number of challenges that limit the wider use of genetic testing in clinical practice. And if anyone has questions for me, there is my email address. Thank you.
Thank you so much again. It was a very interesting talk. And it's really important to understand all these different perspectives and all these different factors, getting into the different neurodevelopmental disorders happening and how they're all interrelated with the patient's awareness as well. And now for a couple of questions. As you showed in that graph where genetic tests cost is reducing significantly, do you think more family-wide genome sequencing should be done instead of just screening for only the patient?
Yeah, no, I absolutely think that's the case, and I probably should have emphasized this in the slides. I think we will get the most insight if we are testing the child and their immediate family. And that's insight, particularly in view of the fact that, de novo variants are more likely to be pathogenic, and we can ascertain that by testing beyond just the child. But also, if we think about scientific discovery and the fact that some of the phenotypes seem to be transferred across family members. That's particularly true of autism, and it's been, recognized for quite a while that, within some families, autism seems to run in the family. So if we genotype beyond the individual, we might get insight into what those mechanisms are that result in the phenotype running across family members. Of course, it's a more expensive option, but I think the arguments in favor of it far outweigh that cost concern. For
a clinic that's getting multiple patients, a lot of patients, and it's very busy, how much do you think automation of interpreting genomic variants, how much do you think that will help with treating the patients and managing everything, and with the families as well, and with the clinicians?
It will help significantly. It's a really important aspect of how we take this forward. So the interpretation of a genetic test has big components of bioinformatic prediction. So whether it be known conservation of particular regions of the genome, whether it's information about how frequent a variant is seen in the population at large and how frequent it's seen in subpopulations. So there are lots of different metrics that you can combine to predict whether a variant is likely to be pathogenic. And you can imagine a scenario where AI methods can usefully interpret all of those different bioinformatic dimensions and come out at the end with a likelihood, with a prediction for that variant. So I really think it's amenable to that. And again, being able to do that is based upon the accumulation of data. You need a lot of data to be able to rely on automation, to rely on computers to be able to make good prediction. But I think we're getting there. A lot of databases are now public, and so it's possible to do these kinds of things. Definitely.
Since you mentioned different populations, do you think ethnic-based genome interpretation, what do you think about that? Like, would it be more accurate? Would it give a clearer picture?
Yeah, it would definitely give a clearer picture. So I think one of the problems with existing data sets is, they're largely estimating population prevalences of variants from Europe, from North America, from Australia. And that tells us about how common those variants are in those populations. And actually, you can distill it down even further, Western Europe, Eastern Europe, and so on. But what we ideally need are data from wider populations, and not only wider populations, but also populations within those populations. I think the frequency of variance in individual populations is definitely a confound to easy interpretation of, for example, GWAS studies. And population stratification is clearly one factor that undermines GWAS studies. So if we're in a position that we have more precise information on the population frequency of different genetic variants, we're in a far stronger position to be able to interpret them correctly.
Definitely. So it's not just getting different populations, but also diving deep into these populations and finding out the different genetic landscape in it.
Yes, within different ethnicities in different populations. Yeah, absolutely.
Definitely. Well, thank you so much, Dr. Woodbury-Smith. This was a very interesting talk, and it was a pleasure having you with us this month.
Thank you very much.